Okay, so this recording is going to talk about our payment basics, billing, insurance companies, that type of thing. So our objectives are to define reimbursement, differentiate between first and third party payers, differentiate between different types of insurance, explain the difference between Medicare Parts A, B, C, and D, and also Medicaid. Examine Medicare reimbursement in a variety of settings, inpatient hospitals, inpatient rehab hospitals. That's your Madonna. There's also a floor on Bryan. I think the name of the company is Select that also does inpatient rehabilitation. Skilled nursing facilities, that's Tabitha, where I still work. The Ambassador, Madonna also has a skilled nursing facility. There's home health and then outpatient facilities. Examine the strategies for cost containment utilized by managed care organizations. You guys are going to understand how documentation is tied to reimbursement, which you've already heard me talk about. And you are going to, after this, be able to construct a physical therapy progress note or daily note using good principles for reimbursement. And that isn't going to come 100% on Friday, but again, it's going to evolve over the quarter. So our overview is going to talk about what is reimbursement, what type of payments are available, and then documentation and reimbursement. So these are all the parties involved in medical financial management. So we have us, the healthcare provider, providing services to the patient, and the patient will either pay us, or if they have insurance, their insurance company will pay us. And as we know, medical expenses can get expensive, and so it is good to have health insurance to help with that, and therapy is no exception, though we are much more cost effective than some other things. So third-party payment or reimbursement, that is when the insurance company pays us. So the APTA has defined reimbursement as payment by either the patient, who is the first party, or the insurer, who is the third party, to the healthcare provider for services provided. And it is that third party that makes us much more accountable in our documentation to prove what we're doing is needed and good for the patient. So reimbursement is accounting for greater than 80% of all payments in rehab. The success of the clinic is dependent upon reimbursement. In the past, I would say this was in the 90s. In the 2000s, it probably changed. Maybe in the late 90s, it started changing. Clinicians would get 100% of what we built out, we would get in. Now we get a percentage of what is billed. So the different types of insurance are social insurance, managed care, casualty insurance, and indemnity insurance. And we'll talk about them each a little bit more. We will spend the most of our time on social insurance because that is for Medicare, Medicaid, and state programs. So it says it's a type of insurance where money is directed from individuals who can pay to those who cannot. I don't know if I necessarily like that definition. Medicare, we get when we get to a certain age, which is going to come up on different slides, but the true definition of social insurance, that is what it is, but not quite how I look at Medicare. So Medicare started because of the Social Security Act of 1965, and it is providing insurance coverage for the elderly and the poor. And then in 1972, it extended its benefits to those with disabilities or permanent kidney failure, and you'll see that as ESRD, end-stage renal disease. Today, it provides benefits to those 65 years of age and older who are receiving or eligible for Social Security retirement benefits. I'll talk about that a little bit more in a second. It is also there for younger people with disabilities who meet Social Security Act's requirements for disability, and then again, those folks with end-stage kidney failure or renal disease. So with those people age 65 and older, they have made some changes lately where when they established Medicare back in the 60s, we were not living as long, and medicine wasn't as advanced as it is now. So I truly am wondering if Medicare is going to be there someday when I reach that age. One of the things they passed a couple years ago was with Social Security. I don't know if it was in the form of a law, but I kind of know this because of my mom retiring. And if you guys have any parents or grandparents retiring, you might know this too. She waited until she was 70 to retire so she could get more money in each Social Security check. The sooner you start Social Security, you're going to get less money per month, but you're getting it for a longer period of time. She went ahead and worked until she was 70 so she could get a bigger chunk, and therefore I cannot remember if she went ahead and signed up for Medicare at age 65 or if she had to wait till she was 70 because she still was getting some health insurance through her employer. And I will say that that is probably a little bit beyond today's PowerPoint, but just something to keep in mind. There are some very complex rules with Medicare. It's going to continue to be that way, and a lot of times folks need help in figuring out when and what they need to do with Medicare. And then, like I said, it was made back in the 1960s. People weren't living as long. Medicine wasn't quite as advanced. I don't think medicine was as expensive as it is today. And so they're really trying to find ways to contain the costs of a program that they made back in the 60s that doesn't quite fit in today's world. And that's where it really has kind of hit us hard as therapists with having to prove what we're doing is truly medical, meets medical necessity. So just something to keep in mind. Medicare and Medicaid, they are coordinated by the Centers for Medicaid and Medicare and Medicaid Services, called CMS. It used to be called the Healthcare Financing Administration, HCFA. I'm familiar with that name. It was out there when I first started practicing, but now you will hear CMS. And CMS administers the Medicare program. It also oversees state Medicaid programs, and it helps administer the CHIP, the Children's Health Insurance Program. So Medicare has 4 different parts. The first part, Medicare Part A, that's going to pay for your inpatient hospital stays, your skilled nursing facilities, your hospice care, and then some home health care. Medicare Part A does not pay for long-term care or nursing home care. So if you have to go into a nursing home, Medicare Part A does not pay for that. It's really just for acute illnesses. And you automatically are enrolled in Medicare Part A when you receive Social Security benefits. Medicare Part B pays for physician services, so like doctor visits and any services that they provide, outpatient services, durable medical equipment, physical therapy not covered by Part A, and occupational therapy not covered Part A. I don't know why they don't have speech therapy in there. I'll talk about that a little bit more. Their enrollment is optional, and there is a monthly premium when you are covered under Part B. So you can kind of look more at Medicare Part B as like your outpatient therapy services. When somebody has a knee replacement and they were in the hospital and they received therapy while in the hospital, that was that whole hospital stay was billed under Medicare Part A. They got discharged, they were able to go home, and now they're coming into a clinic to get services. That clinic could be at the hospital in an outpatient clinic, or it could be a standalone outpatient clinic, and they're going to be under Medicare Part B at that time. Medicare Part C's and D. Part C is called Advantage Plans, and those are administered by a private insurance company, and they combine parts of A and B. And the thing about Medicare Part C is it's more like a managed care plan, which we're going to talk about. If you guys are familiar with HMOs, they're a lot more stickler on what the patient gets. Their days are going to be more limited. You're going to have to do more paperwork at regular intervals to prove, yes, they need therapy. If I ever, from my experience in the clinic, if I had to give my mom advice when signing up for Medicare Part A or Part B, or Part A or doing an Advantage plan, I would have told her to do A and B. Don't do the Advantage plan. And then Part D is the prescription drug coverage. Okay. So Medicare contracts with private insurance companies to pay the bills. So the bills that we as therapists submit to Medicare, they do not go all the way to Washington, D.C. and then come back. They're kind of split by region. And I have some PDFs up on Moodle that you can also look at showing who the private insurance company is that administers Medicare for our area in Nebraska. So that's kind of interesting. I think it's called Wisconsin Physician Services, something like that, but we'll be able to take a look at that in Moodle, and then I'll also point it out in class. So they're called an Medicare Administrative Contractor, and that is also referred to as a MAC, M-A-C. So you'll hear that. And like I kind of explained, it's defined by a geographic region. And if you guys want to look at this link on your own time, it'll show you where all the different MACs are in the United States. They have maps out, they have tables, lots of extra information. I'm going to go back here for a second, and I kind of pointed out what geographic region is Nebraska in. That is something that you'll be able to look at when we look at those PDFs that I have on Moodle, giving you information on the MACs. So Medicare reimbursement, it varies on the type of facility you're in. It can be with a prospective payment system or a PPS. When you have a PPS, it's based on a predetermined fixed amount, and the patients are categorized upon admission based on their diagnosis, their disease, and their functional status. And then you can also have a case mix adjustment, and that is based on the geographic location, if it's a teaching or a non-teaching hospital, and the number of patients you serve with or without insurance. So we'll talk about that in an upcoming slide a little bit more when there's a table. PPS, so each setting is unique. They use assessment tools to help determine that prepayment that they're going to get for whatever condition. There's different categories and there's guidelines. So the PPS is in place in acute care hospitals, inpatient rehab hospitals. Again, that's your Madonna Acute Rehab Hospital. Your SNFs, skilled nursing facilities, you'll get familiar with that acronym SNFs, and then home health care. So here, looking at this table, you see in the acute care hospital, the assessment depends on the diagnosis, the type of treatment, their age, and other relevant criteria. So that could be like their comorbidities. And so they'll be put into a diagnosis-related group. So you'll hear that referred to as a DRG. So if you're working in an acute care hospital, it's like the hospital gets paid a lump sum of money on that diagnosis-related group. So it's up to the hospital to be very efficient with what they do with that money that they get. And so what you'll really find, and I'd be interesting to see if it's still kind of a trend, and I think it is acute care hospitals, they are getting people out of the door as soon as possible, especially those Medicare patients in those DRG groups, because the longer they're staying there, the more they're taking away from that pot of money that they received in that DRG. So your skilled nursing facility, your SNF, its assessment is called the MDS. That's usually done by an MDS coordinator who's a nurse, and she gathers a bunch of information and data about the patient, and that helps figure out what type of payment that SNF is going to get. And then the patient categorization is called a resource utilization group, or a RUG. And this is where physical therapy, occupational therapy, and speech therapy really come into play, because the more minutes that a patient needs to be seen in a skilled nursing facility, the higher level of payment you're going to get for that. And that is something that I'm not going to explain over the PowerPoint. It's going to be an activity that we do in class to help you understand that RUG and the SNF system of payment. Then you have your inpatient rehab facility, so that's Madonna. And so this is where Joyce can kind of help us be a little more familiar, because she's used to working with that. And the assessment is called an IRF-PAI, and it utilizes the FIM, which is the Functional Independence Measure. We will go over that when we do our measurements and testing, I believe, in a week or so. And then that patient categorization is in case mixed groups. Then final setting is home health, and the assessment is called the OASIS. And that is done by the first person into the home. So if you, so you guys as PTAs won't have to do it. You will probably be doing data collection to go towards the OASIS, but it's very interesting because as a physical therapist, if I was the first one in and the only one in, I would have to do the OASIS. And it really kind of broaden my horizons because I'd have to look at all the medications the patient was taking. You really have to look at their home setup. You know, when you're out in home health, there's a lot of things. You still have a team to kind of back you up, but there's a lot of things that you kind of have to learn how to do on your own too. So with patient categorization, that also uses case mixed groups. And on one of the last slides of this PowerPoint, some of the ways that they're reimbursing is going to be changing. And so this is what is true now, but it may not be true in a year or so. And I'll kind of give you guys a snapshot of that. But you're just going to have to be ready to have some changes in how you do things. And I think overall it'll be okay, especially when you guys are new and out, and you'll be flexible and you won't have been doing it a certain way for a long period of time. So I talked a little bit about the DRGs, and you can read here, a classification system that groups patients according to their diagnosis, their type of treatment, age, and other criteria. Hospitals are paid a set fee for treating patients in a single DRG category, regardless of that actual cost of care for the individual. So like I said, based on that DRG, they're given this pot of money, and you know, the longer that they stay in the hospital, the more that pot of money is going to get eaten away at, and they're not going to be able to make money or, you know, stay in business if they're a non-for-profit. So very interesting and complicated way of getting paid. So your RUGs, classification hierarchy, groups patients according to the amount of resources needed during the SNF stay. So it can depend on rehab, their services, their special care, how clinically complex they are, if they have impaired cognition, behavioral problems, or reduced physical functioning. And I tell you what, maybe it was just because I was in therapy, but they really focused here on rehabilitation. And I tell you what, when you went up in their levels of minutes or the amount of rehab they get, you definitely get more money. So kind of an interesting thing, and it does lead to fraud and abuse, which is our second PowerPoint that we'll be going over this week. The case mixed group is a distribution of patients into categories reflecting differences in their severity of their illness or resource consumption. And then that minimum data set, that's what you get in skilled nursing. Again, it involves a multidisciplinary assessment for skilled nursing facilities. You have an MDS coordinator, and she gathers all that information, but we do contribute to it with helping them know what their ADL status is, nursing needs, that's how nursing contributes to it, their behavioral status, and their cognitive status. So one of the things about those MDS coordinators, they are going to be very well versed in completing the MDS, and they're going to find ways to maximize reimbursement. The functional independence measure, I'll just go ahead and read this out. It's a standardized multidisciplinary evaluation tool often used to score the patient's performance in self-care, bowel and bladder management, transfers, gait and or wheelchair mobility, communication, and cognition. The patients are scored from 1 to 7, 1 equaling total assist, 7 equaling to independent, and it's according to the level of assist they require to complete the task. So we'll get into that a little bit more as we do the testing and measurement outcomes testing section. The OASIS, so this is an assessment for patients receiving home health services. It's performed on every patient receiving services from home health agencies that are approved to participate in Medicare or Medicaid programs. So home health agencies, or you'll see them called HAA, they do have to go through some strict things to be able to participate with Medicare and Medicaid. So that is also kind of interesting. I know of a place in Lincoln, I will not name its name, but one of the requirements for home health is that you have to be considered homebound, meaning it is taxing and difficult to leave home. Well, there was a skilled nursing facility in town that was trying to act like a home health agency, but they said, we'll come in and provide services to your home and you don't have to be homebound. Well, that was not legal and they did get caught for that. So kind of an interesting side story. All right, now we're to the MPFS, Medicare Physician Fee Schedule. It is a predetermined list of payments, payment amounts for services performed by physicians of healthcare providers. The predetermined amount is known as the Medicare allowable, so if you hear of that, Medicare reimburses 80% of the Medicare allowable, then the remaining 20% is paid by the patient or their secondary insurance. The MPFS is like a prospective payment system for physical therapy, occupational therapy, and speech therapy. And it also determines reimbursement for hospital-based therapy, outpatient clinics, and physical therapy private practices. It is kind of interesting as you go out into the clinic and you delve into understanding insurance and billing a little bit more. Medicare does not treat private therapy practices, standalone private physical therapy practices, the same as hospital-based therapy outpatient clinics. And I can tell you a little bit more about that in class. But know that it is kind of interesting how they do that. So the MPFS basically determines how much we get paid for each service we charge. And your assignment this week, which is the worksheet module, or the payment module or worksheet module, that you'll be going to the APTA site to fill in some information. You will see how much Medicare actually reimburses us for what we do. And I'm not going to give you any more information on that. I'll let you see for yourself what those reimbursement numbers are. It's kind of interesting. So as you see, if I have written in the notes down here, a fee schedule is a complete listing of fees used by Medicare to pay doctors and other providers or suppliers. This comprehensive listing of fee maximums is used to reimburse a physician and other providers on a fee-for-service basis. So that is a little bit of information that I got from CMS's site. All right, the Medicare allowable. This is determined by an elaborate coding system. And then all healthcare procedures are assigned a code under current procedural terminology, or CPT. And then under the CPT system, physical therapy procedures typically begin with a 9-7. So this is something you guys do need to know, CPT codes, because you will be billing patients for services, and you'll be doing that by using CPT codes. Okay, your CPT is a medical code set of physician and other services maintained and copyrighted by the American Medical Association and adopted by the Secretary of the Department of Health and Human Services as the standard for reporting physician and other services on standard transactions. It is used by physical therapists and also other healthcare providers to describe the interventions that were given to the patient. And I also have a PDF up on Moodle showing the different CPT codes and what they mean. And again, that payment module or worksheet is going to help you guys get a little bit more familiar with that. Each CPT code is assigned a weight based on the provider work value to administer the procedure, how much it costs to perform the procedure, the professional liability value, and the scale used is called the Resource-Based Relative Value Scale, RBRVS. That's something that you guys will not be tested over, that RBRVS, but some of these other acronyms you guys need to know. CPT, CMS, SNF, Skilled Nursing Facility, RUGs, DRGs, those you want to be pretty familiar with. me see, I lost where I am. Okay. So once that resource-based relative value scale, that is a mouthful, has been determined, it is multiplied by a conversion factor. The conversion factor is applied, then the value is adjusted for geographic region. So for example, I'd look at this as, California has a much higher, not better, higher cost of living than we do in Nebraska. So they're going to get reimbursed at rates different than what we are here in the Midwest. Medicare and other third-party payers use that CPT coding system, so it's not just Medicare, it's other insurance companies to help establish a fee schedule. And then again, like I said, the majority of codes are in the 9700 series. So here's some examples. So 97530 is called therapeutic activities, 97035 is ultrasound, and 97140 is manual therapy. And again, you guys are going to get to start to be familiar with this, but we're going to get into that a little bit more as to what activities or exercises or interventions fall under therapeutic activities, what type of things fall under manual therapy. Ultrasound is pretty obvious what falls under there. And then I've already kind of given you guys a little information about the 8-minute rule. And here we're really going to delve into this because you guys are going to start practicing how to bill for your services. So 1 unit of a CPT code or a service has to be between 8 and 22 minutes. 2 units, it can be the same CPT code, or it could be you're doing a TheraX with them and then a neuromuscular re-ed. Those would both be those together would be 1 unit of one and 1 unit of the other, equaling 2 units. And the time that you spend doing them has to be between that 23 and 37-minute number. Okay, in order to get up to 3 units, and again, it can be 3 units of the same thing. Medicare doesn't necessarily like it when you get a lot of units of the same thing, and I'll talk about that in class. But if you get up to 3 units, it's between 38 and 52 minutes. 4 units is 53 and 67 minutes. 5 is at 68 to 82, and 6 is 83 to 97. So if you kind of look at this too, 15 minutes, 30 minutes, 45 minutes, 60 minutes, 75 minutes, and 90 minutes kind of fall in between there. So that's how they kind of looked at those units, 15, 30, 45, 60, 75, 90. But then you see we have this range in there. So any questions about that, we'll answer them in class. The alternative payment models are something that is on the horizon, and I kind of alluded to earlier that things could be changing in the near future for how we are reimbursed. Just going to give you a little information on them now. One example is a merit-based incentive payment system. This combines some things you guys might not be 100% familiar with. The Physician Quality Reporting System, or PQRS. PQRS is something that Medicare required us to do as therapists, and mostly the physical therapists were responsible for it, but it was basically, we were gathering data for Medicare, and I'm sure they're analyzing all that data right now. And I'll explain it to you a little bit more in class. So using electronic records and a value-based system. And then we also have an advanced alternative payment model, or an APM. It's a movement away from a fee-for-service and toward a bundled payment. Lincoln, Nebraska was fortunately or unfortunately chosen for a Medicare pilot program where joint replacement surgeries, knee joint or total hip joint replacement surgeries, were put under a bundled payment system. So somebody had a knee replacement, the hospital got a lump sum of money, and if somebody had to go to skilled care, that lump sum of money had to get distributed to the skilled care, and then when they had to go to outpatient, it had to get distributed to the outpatient. And so then the hospitals with the DRGs, you had that pot of money within the hospital with the bundled payment. You like have this one payment for this one episode of care, total knee replacement, and it has to get distributed out amongst the providers of that care until that patient is completely discharged. So it's a lump sum payment for the hospital, for the skilled nursing facilities if the patient goes there, for home health agencies if they go there, for outpatient clinics. So guess what the push has been then for total knee replacements? When they are in a bundle payment system, they're going to bypass skilled nursing because that eats a lot more money than home health. So they would try to either get them to home health, but even more advantageous to the hospitals with that big bundled payment is to get them into an outpatient clinic. And then once they're in that outpatient clinic, they're going to even be really questioning you on how much you need to see that patient. So good or bad, I have my strong opinions about that I'll share. But it's just kind of the world that we live in and how we have to work around things. So this bullet point, or number one underneath here in the notes, physicians had to start participating in MIPS, and MIPS looks at quality, promoting interoperability, clinical improvement activities, and cost. When PTs and PT clinics are going to be part of the MIPS, they only are going to look at the quality and clinical improvement activities. And this is really where those outcome measures are going to come into play, where we have to prove that what we're doing is helping the patient. And the outcome measures have been studied extensively, and they are able to be studied and show that patients can really prove progress. So here, I need to pause because my son is in here. Say hi, Jaden. Say hi, PTA class. You gotta talk louder. Hi, PTA. Okay. Okay, I am back. That is enough information on alternative payment models. All right, Medicaid, you guys have probably heard of Medicaid. It's a joint federal and state funded program, pays for medical care for individuals and families with low income and resources. And some eligibility requirements include age 65 and older, pregnant, blind, disabled, low income, U.S. or citizen or lawful immigrant, and children 18 and under and younger with certain criteria. I guess that's all we're talking about. Medicaid, you know, it's administered by state and federal, but mostly you're going to be dealing with state health and human services when you have any issues with Medicaid. In the state of Nebraska, we've been having a lot of difficulties with the insurance companies who administer Medicaid and approving physical therapy visits and then denying a lot of claims. And then this is where things get kind of sticky. Medicaid and Medicare, for that matter, don't reimburse stuff very well to begin with, and they give you a lot more paperwork and red tape to deal with on top of that. So you can kind of see where I'm going with that, but we'll talk about that more in class. Okay, if a procedure is not going to be covered under Medicare or Medicaid, there's certain things you have to do. So this is in a case where you as a provider believes the patient would still benefit from a procedure that may not be covered, and the patient agrees to pay with it. You have to have them sign what's called an ABN, an Advanced Beneficiary Notice. And so then the day that you provide that service, the ABN must be signed on that day, and that way the patient understands they could be responsible for payment if Medicare or Medicaid does not cover the service. If the provider believes that a patient would benefit from a procedure they are certain will not be covered, then they have to require the patient to sign a notice of exclusion of Medicare benefits, an NEMB. And that is something new that has come along since I've been in the clinic. So probably in the last 3 years, or else my facility was not doing that, which is very possible. Managed care, this is where we get into our PPOs and HMOs. So this is probably something you guys are more familiar with, because if you were ever covered by insurance with your parents, it was something, probably the type of insurance that you had with them. So managed care strategies, so they're just trying to help control costs, because we know medical services cost a lot of money these days. So it limits the number of providers a patient can use through networks. It limits the amount of payment to providers through fee schedules. It can require prior authorization. It can limit the number or duration of services provided. It can require a utilization review process, and requires case management. So we're going to talk a little bit about these. A utilization review is an examination of the medical necessity, economic appropriateness, and quality of care provided by patients by a healthcare provider. Reviews may be conducted by either an internal staff person or a committee, or by an external independent review organization. So I know Bryan Hospital, for example, they have departments, or maybe it's even the directors of the department, that will audit charts, and they'll review them for their accuracy and that type of thing. Case management is the process used by a doctor, nurse, or other health professional to manage an individual's health care. Case managers make sure the patient gets needed services and tracks the patient's use of their facilities and resources. Point of service plan. So patients choose a PCP within the network. That's going to be a doctor. Patients who choose to go outside the network must pay additional costs. The PCP is the point of access into the healthcare system. So for instance, you can't just, with some plans, say, hey, I need to go to a neurosurgeon for something. You have to see your PCP first and then get referred to that neurosurgeon. And then this is where you get into reimbursement for physical therapy too. Nebraska is a direct access state, but we have to go through, for a lot of our plans, go through a doctor, get that doctor's prescription or referral in order for them to pay for the services of therapy. And then the PCP can direct the patient's care or refer to a specialist, like I just kind of explained. Your primary provider is your physician responsible for point of entry into the healthcare system. So the first one that the patient should go see if they have somebody. So usually it's a family physician. It can also be a GP, an internal medicine, and some cases it can be an OBGYN doc. Networks, so that's a group of providers that are enrolled within a specific insurance group. So I'm part of Blue Cross Blue Shield. If I want to go to somebody, I can go on the website and see if they are part of the group that I'm in, and that might be something that you guys are also familiar with. The PPO, it's an insurance plan where healthcare providers contract with an insurance company to treat policyholders and form into a predetermined fee schedule. So again, we're not getting reimbursed at 100% of what we bill out. It's a predetermined schedule, but it's usually a pretty good percentage and better than what Medicare pays. The range from one hospital and its practicing physicians to a national network of providers. It just depends on the insurance. It provides discounts from standard fees, incentives for plan enrollees to use contracting providers, and other managed care cost containment. So if they go outside of the network, the patient could end up paying more. So your HMO is your health maintenance organization. So it's a medical group practice plan that acts as both an insured and healthcare provider. The group participants are entitled to services from participating physicians, clinics, and hospitals for a flat monthly or quarterly fee. So with HMOs, I'd say they're a little bit more stickler, where you can't really go outside their system. Like you can a PPO, you will probably not get very much, if any, reimbursement if you go outside your HMO, whereas with a PPO, they'll still reimburse some, but not as, for most of the plans, I could be wrong, but not as much as if you stay within that preferred provider network. Casualty insurance are those who are injured on the job or in a motor vehicle accident. So auto insurance, the claims are handled by payers other than insurance companies. So I think of that with auto insurance, and then also workers' compensation. Workers' comp plans are run by state governments, reimbursement, and the benefits can vary from state to state. These are you can read their 6 basic benefits. Something that's interesting in the notes down here is one expectation is that employees must wait 3 to 7 days before receiving workers' comp benefits, and then if they're not able to go back to work after those 3 to 7 days, they'll receive benefits, and that's like workers' comp pay. Or disability payments. That's not getting medical care. They can get medical care right away. If they have to be off of work, they will not get paid anything, or they might have to take their sick days or vacation days for 3 to 7 days before they actually receive that workers' comp check. And then indemnity insurance, that is the Aflac duck. That's your indemnity insurance. It doesn't provide payment to the healthcare provider, but it can go right to the insurance company. I myself have hospital indemnity insurance. I pay about $20 a month for it. It's been really valuable because they paid me for when I was in the hospital when I had my kids, and so that kind of helped make up for the lack of a paycheck when I was at home with my kiddo. And here on this next slide, you see cash-based services. This is something that's probably becoming a little bit more popular than what it used to be because of how convoluted the reimbursement process has become, with insurance companies not paying 100% for services that you do, having to go through all the paperwork and red tape to even get paid in the first place. So you just make a deal between you and the patient, and you get paid in cash for what you do. The patient pays the bill in full each day the services are provided. As you see, more therapy clinics are incorporating that cash-based services, and this helps decrease dependence on third-party payers. It can only probably be the patients who can actually pay, and it eliminates the stipulations on how you treat those people. PPOs are usually very good types of insurance to have, but usually they'll have a set number of days for therapy per year. Last I knew, some Blue Cross Blue Shield plans were 60 visits per year for physical therapy. I cannot remember, it was OT and speech combined, but that's still pretty good compared to some. United Healthcare, UHC is one of them, that was always kind of very stickler on the number of visits we got, and we had to do a lot of paperwork and things to be able to get approval for more visits. So as you see, this bullet point at the bottom, the patient may not be able to afford the needed services, and that happens. We do still have some people out there who cannot afford insurance, and so sometimes they get hurt. They have to find some way to pay for it. Your pro bono services are for the public good. It's service provided at no charge. It can be provided by a physical therapist or physical therapist assistant. So typo on the PowerPoint's part. It's provided for patients without insurance or inadequate coverage for rehab services. And there's some specialty clinics. There can be PT clinics, and then they can be associated with a physical therapist or physical therapist assistant school. I think UNMC at one time had a pro bono clinic, and they might still have it at this time for physical therapy. All right, documentation and reimbursement. So why are we telling you all about insurance when we're in our documentation section? Well, Medicare and Medicaid require physicians and other healthcare providers to document medical procedures in order to be reimbursed. So we always keep in mind that payment can depend on what you write in your progress or daily notes, and the key points to include the ongoing need for skilled interventions and how those interventions bring about functional improvement. I think I've already drilled that into your guys' heads pretty well. To maximize reimbursement, again, we've gone over this in previous PowerPoints, but you want to reflect a comparison between the patient's current functional status and his and her functional status at the initial eval. You'll include their impairments, functional limitations, degree of disability in a clear, concise, objective, and measurable language. Maximize the use of objective tests and measures, and distinguish between verbal and physical assistance. You want to include regular patient updates. Updates must be provided in a manner consistent with those on the initial eval. indicate why a process might be slower than expected, and provide adequate information to support medical necessity of each treatment procedure on every date it was billed. That sounds like a very monumentous job, but once you guys get used to doing it, it won't be so bad. Maximize reimbursement, provide evidence that unique services of a therapist are required. You guys have heard this before. This includes recording the patient's response to treatment and recommending a reevaluation for changes to the treatment plan when necessary. Include the time spent delivering each service, and include a description of the service provided in language that is consistent with what is billed. All right, only 2 more slides to go. Something that I want you guys to know about that just happened was the Medicare therapy cap reveal in 2018. In 1999, when I graduated from physical therapy school, Congress passed the Balanced Budget Act, BBA. What that did was it placed a cap on outpatient occupational therapy services and outpatient physical therapy and speech therapy services combined. The reason why they combined speech and PT was because of a grammatical error. Anyway, there was a cap on what Medicare beneficiaries could receive in outpatient clinics. I'll talk about it a little bit more in class, but it was $1,800 back, I think, when I graduated, maybe even $1,600, that they would be limited. Well, if you get a person with a stroke who needs OT, PT, and speech, they would probably be out of $1,600 within 1 or 2 months of the start of the calendar year. So Medicare came up with this thing called a KX modifier that would allow you to go above the cap, but you still had to tread very lightly. Hey, the nice thing in 2018 is this therapy cap was finally repealed. So they have been working to get it repealed for probably 17, 18 years. The bad thing about repealing the therapy cap is they decided to change how you would be reimbursed if a physical therapist assistant or an occupational therapist assistant provided the care. Instead of getting paid at 100% of what Medicare pays you, which is not that great to begin with, when you see that a PTA or an OTA provided the treatment, they're going to reimburse at 85% of the usual rate. This will not take place until January 1st, 2022. I know the APTA and the AOTA are working to have this not be as much of an impact as what it looks like it's going to be, but it is still something to be aware of. In my research on this, beginning in 2020, CMS may start requiring modifiers to show if it is a PTA providing the services. So they're not going to start docking rehab, they're going to start tracking it in 2020 very possibly. Another thing is, even though the cap has been repealed, when billing is submitted, they're still going to have to put this little thing called a KX modifier showing that we went above a $2,000 level, and then all things are going to be reviewed if they exceed $3,000. So kind of an interesting thing. But on the flip side, we're going to end on a happy note. TRICARE. TRICARE is insurance for active duty military personnel, retirees, and their families. And TRICARE used to not allow PTAs to see their patients. They would not allow it. Only a PT could see their patient for them to get reimbursed. The APTA worked hard and they got this repealed. President Trump signed this into law, but it still has yet to be enacted by the Health and Human Services or the VA, whoever does that for them. So PTAs will now be able to see TRICARE patients where in the past they couldn't, but still there's still working through getting it actually established. So, and there are your resources.